Good morning. A quorum being present, the subcommittee will come to order. Welcome to today's subcommittee hearing. I would like to thank our panel of witnesses and our members for joining today's important discussion about the opioid epidemic and its implications for the Federal Employees Compensation Act, the FECA program. Across the country, prescription opioids account for an alarming 40% of opioid fatalities. The national opioid epidemic, which late last year was classified as a public health emergency by President Trump, is devastating communities, workplaces, and the lives of working Americans across the country, including our federal workers. According to the National Council on Alcohol and Drug Dependence, 70% of Americans misusing drugs, including opioids, are currently employed, a fact that has a significant impact on workplace health and vitality. This public health emergency is not only impacting employees and employers in the private sector, but also has serious implications for the Department of Labor's FECA program, which was responsible for workers' compensation coverage for nearly 3 million federal employees nationwide. FECA provides public sector employees with workers' compensation benefits in the event of an illness or injury sustained in the performance of duty. FECA benefits include wage replacement, reasonable and necessary medical treatment related to the injury, vocational rehabilitation and job placement assistance for disabled workers, and compensation for any impairment that results from the injury. For years, the go-to treatment for many employees injured in the line of work was an opioid prescription. As prescribing practices have changed in the health sector, change has been slower in workers' compensation programs. In 2016, the U.S. opioid prescribing rate was 61 prescriptions per 100 persons. However, according to the National Council on Workers' Compensation Insurance, insured workers who were given at least one prescription in 2017 received 3 times as many opioid prescriptions as the U.S. prescribing rate. Additionally, local prescribing practices vary widely from state to state, and those practices may play a significant role in whether an injured federal worker receives an opioid prescription through the FECA program for an on-the-job injury. In May 2017, the Department of Labor's Office of Workers' Compensation Programs announced changes to the FECA program to limit opioid prescribing practices and combat opioid abuse in the program. We applaud OWCP for these efforts, which are good first steps to limit the spread of unnecessary opioid prescriptions, where a non-addictive alternative would be just as effective. However, challenges still remain. Due to the broad geographical reach of federal employees and the discrepancies in state-by-state prescribing practices, it is important for members of the subcommittee to understand how opioids are prescribed to federal workers through the FECA program, and learn what steps can be taken to ensure the opioid epidemic is not being perpetuated through the use of federal government resources. Today, we will hear from experts familiar with the Department of Labor's programs and initiatives, and the inner workings of both federal and state workers' compensation programs. Their testimony will provide members with invaluable insight into the opioid public health emergency and its implications for the FECA program. I look forward to hearing from our panel of witnesses and from other members of the subcommittee today as we examine the relationship between the Federal Workers' Compensation Program and the national opioid epidemic. I now yield to today's ranking member, Mr. Desaulniers, for his opening remarks. Mr. Desaulniers.
Thank you, Mr. Chairman. I want to thank our witnesses and look forward to the hearing, and thank you for having this hearing. It is troubling to be here to look at something that was meant to alleviate pain, which has caused so much pain, in its relationship to the federal workforce. And it's timely to examine the Federal Employees Compensation Program and the policies the Department has adopted regarding opioid prescriptions. We cannot overlook the magnitude of the opioid problem. In a November 2017 report, the President's Council of Economic Advisors estimated that the opioid epidemic in the United States is costing a startling $504 billion in 2015, when accounting for both the fatal and non-fatal costs. Put into context, this equals 2.8% of the gross domestic product. The Department of Labor receives 118,000 occupational injury and illness claims from federal and postal workers each year. I want to be clear that protecting these workers from workplace injuries, which are oftentimes avoidable, should be our first line of defense. Should an injury or illness occur, ensuring that workers receive timely and appropriate care through FECA is the priority, and this often includes a care for pain management. However, we must also examine whether the current DOL policy is appropriate and effective. DOL recently adopted policies to address opioid dependencies in its FECA program. The department now authorizes 60 days for initial opioid prescriptions, but requires prior authorization for refilling prescriptions after the initial 60-day time period. By contrast, California's Division of Industrial and Labor Relations adopted a formula which allows a 4-day supply for opioids after surgery or injury, but requires pre-authorization for refills and prior authorization for any opioid prescription outside those narrow circumstances. Providing a robust level of case management requires adequate resources. DOL staff in the FECA program has dropped from 734 full-time equivalents in 2013 down to a projected 626 in the 2019 budget. DOL simply lacks the staff to carry out extensive oversight and robust management, much less take the path followed by my home state of California. Moreover, DOL's opioid policies are still a work in progress, since the department does not have a policy covering those who have been on opioids for a lengthy period of time. Mr. Chairman, I would also note that DOL is conspicuously absent from today's hearing, unfortunately, even though it's their opioid program that we are reviewing. I would respectfully ask that you invite them to provide data and discuss their program at a subsequent hearing. It is no secret that DOL's Office of Workers' Compensation Programs has been challenged to better manage prescription drug costs. Postal and Labor Department Inspector Generals have issued reports documenting a systemic failure to prevent payments for exorbitantly priced compounded pharmaceuticals, many of which have dubious clinical benefit and in some cases include opioids. For that reason, I am pleased that we have the Inspector General with us today. Criminal conduct by pharmacies and physicians have fleeced the FECA program as well as state workers' compensation programs, Medicare Part D and TRICARE, and it is therefore imperative that this committee should review the legislative recommendations from the Inspector General regarding compounded drugs in the FECA program. As we think about this problem, let us not overlook the history of how the well-organized dangers of opioid addiction, which was taught in medical schools, were turned on their head by shoddy science and avarice. It begins with a one-paragraph letter to the editor of the New England Journal of Medicine, which was tucked into the back pages of a 1980 issue. This letter reported that there were only 4 cases of opiate addiction out of 12,000 patients who were treated in hospitals prior to 1979. However, this letter did not address how often, how long, or at what dose levels patients received opioids. As documented in the book Dreamland, that obscure letter was cited in reports in prestigious journals which inflated this one-paragraph letter into, quotes, a landmark study, proving opioids were not addictive. In the hands of Purdue pharmaceutical salesmen, oxycodone was marketed as a non-addictive pharmaceutical. The Sackler family became billionaires as they acquired the 16th largest fortune in this country and built museums in their name. Unfortunately, these ill-gotten gains have not been turned back over to the American people to help defray the costs of this fraud, much less bring back the lives that have been lost. We know that long-term use of opioids begins with the treatment of acute pain. The Center for Disease Control reports that a prescription for a 30-day regimen of opiates results in 35% of the patients still taking those drugs a year later. This is playing with fire. Mr. Chairman, I hope our witnesses today can compare best practices in the states with the Department of Labor's opioid policy and help chart a path for this committee's continued oversight. I thank you, and I yield back the balance of my time.
Thank you, Mr. Desaulniers. Pursuant to Committee Rule 7C, all subcommittee members will be permitted to submit written statements to be included in the permanent hearing record. Without objection, the hearing record will remain open for 14 days to allow statements, questions for the records, and other extraneous material referenced during the hearing to be submitted in the official hearing record. Now, it's my pleasure to introduce today's witnesses. Dr. Scott Simondera is the acting section research manager at the U.S. Library of Congress Congressional Research Service. Ms. Ramona Tanabe is the executive vice president and counsel at the Workers' Compensation Research Institute in Boston, Massachusetts. Mr. Joe Peduto is president of Comp Pharma, LLC in Maggie Valley, North Carolina. And the Honorable Scott Dahl is the Inspector General for the U.S. Department of Labor. I will now ask our witnesses to raise your right hand. Do you solemnly swear or affirm the testimony you are about to give will be the truth, the whole truth, and nothing but the truth? Yes. Let the record reflect the witnesses answered in the affirmative. Before I recognize you to provide your testimony, let me briefly explain our lighting system. You each will have 5 minutes to present your testimony. When you begin, the light in front of you will turn green. When 1 minute is left, the light will turn yellow. Like when you're driving a car, that means slow down, except we may want you to speed up. When your time has expired, the light will turn red. Now, I am not heavy-handed with the gavel, but I do want you to try to wrap up as quickly as you can. So you may hear me at that point ask you to wrap up your remarks as best you are able. And after each of you have testified, members will each have 5 minutes to ask questions. So let me recognize each of you for your 5-minute opening statement, and we'll start with you, Dr. Simondera.
Thank you. Chairman Byrne, Chairman Fox, ranking members Scott and Desenier, and members of the Subcommittee on Workforce Protections. My name is Scott Simondera. I am with the Congressional Research Service. Thank you for inviting CRS to testify before the Subcommittee on the Federal Employees Compensation Act, or FECA, and the implication of the nation's ongoing opioid epidemic on this workers' compensation program. Since 1916, federal employees have been protected from economic losses associated with employment-related injuries and illnesses, and their families have been protected in cases of employment-related deaths by FECA. Like state workers' compensation systems, FECA and the other federal workers' compensation programs are facing increasing pressure from the nation's opioid epidemic. In addition to cash benefits to partially replace earnings lost due to disability, FECA provides medical care and coverage, including prescription drugs, for beneficiaries with employment-related injuries and illnesses. FECA medical benefits are designed only to provide medically necessary care for covered employment-related conditions. The FECA statute mandates that the care provided must be recommended or prescribed by a qualified physician and must be considered by the Secretary of Labor to be, quote, likely to cure, give relief, reduce the degree or the period of disability, or aid in lessening the amount of the monthly compensation. If recommended or prescribed by a physician, the cost of certain complementary and alternative treatments, such as acupuncture, may be paid by FECA, provided they are determined by OWCP to be medically necessary. In part, due to the nature of work injuries, which frequently involve pain, opioids make up a large portion of the total utilization of prescription drugs in workers' compensation programs. For example, one large pharmacy benefits manager reports that despite recent decreases in overall opioid use within workers' compensation, owing in part to legislative and regulatory changes made in the states, among workers' compensation prescriptions at its services, opioids constitute the largest class of medications prescribed, making up approximately 23% of the utilization of medications and 24% of annual workers' compensation medication spending. The National Council on Compensation Insurance reports that in 2016, workers' compensation beneficiaries who received at least one prescription received 3 times the national average number of opioid prescriptions. Recent research by the National Bureau of Economic Research on the experiences of individuals with employment-related low back pain found that prolonged use of opioids was linked to longer durations of disability, and that, compared to similarly injured workers who were not treated with opioids, long-term opioid use nearly tripled the duration of disability. OWCP first began to limit access to opioids in 2001 when it placed limits on the use of the drug OxyContin in the federal Black Lung Benefits Program. This was followed by limits on Schedule II drugs in the FECA program in 2009 and a policy limiting the use of fentanyl to FECA beneficiaries with cancer in 2011. In June 2017, OWCP issued guidelines for the prescription of opioids in the FECA program. At this time, these guidelines only apply to cases in which no opioid has previously been prescribed within the past 180 days and do not apply to cancer cases. The 2017 guidelines require a letter of medical necessity from the beneficiary's physician or prior authorization by OWCP before any opioid fills after an initial 60-day period, with each letter of medical necessity and OWCP authorization being valid for 60 days. Continued use of an opioid may only be authorized beyond 120 days from the initial fill if the claims examiner has written to the physician requesting rationalized medical justification for the ongoing use of opioids. In addition, all cases with continued opioid use should be reviewed every 6 months by either an OWCP district medical advisor or via a second opinion examination of the beneficiary provided by OWCP. It may be too early to determine the full impact of these policy changes on opioid use within the FECA program. In addition, these new policies on initial and subsequent authorizations currently only apply to beneficiaries with new opioid prescriptions, rather than those who are currently involved in the long-term use of opioids. Thus, it remains to be seen how OWCP will address those beneficiaries who have been taking opioids for more than 180 days, especially in light of recent research showing links between long-term opioid use and disability duration. This concludes the testimony of the Congressional Research Service. I'm happy to answer any questions that the subcommittee may have.
Thank you, Dr. Simondera. Ms. Tanabe, we're calling you for 5 minutes.
Good morning, and thank you, Chairman Byrne, Ranking Member DeSagne, and members of the subcommittee for inviting me to speak about the research of the Workers' Compensation Research Institute in the area of opioids. My name is Ramona Tanabe, and I'm the Executive Vice President and Counsel for the Workers' Compensation Research Institute. WCRI is a not-for-profit public policy research organization located in Cambridge, Massachusetts. WCRI provides information to all stakeholders in the workers' compensation systems, and that information is regularly used in the public policy debates. WCRI does not take positions on policy, nor do we make recommendations. Today, I summarize findings from our studies on opioids, specifically how opioid utilization varies across states and how it is changing over time. I'll also describe what policies have been implemented by states and results from our comparative studies. The WCRI studies on opioids use data across 26 state workers' compensation systems. Our latest reports show large decreases in the average amount of opioids dispensed to injured workers in many states. In 4 states, Kentucky, Maryland, Michigan, and New York, the decrease was 30 to 40%. Other studies outside of workers' compensation also noticed a reversal in the trend of opioid prescribing over this period after a consistent and rapid increase starting in the 1990s. This turning point may be associated with changes at the federal, state, and organization levels in recent years to address opioid use. One result of the changes in opioid use over this period is the narrowing of the extent of variation across states. However, we still see some variation, approximately 4 times the average amount of opioids dispensed to injured workers in the highest state compared to the lowest state. We also saw large differences in the frequency of claims receiving opioids on a longer-term basis and at higher doses. In the typical or median study state, 13% of claims with opioids received at least a 60-day supply of opioids over any 90-day period, which is a measure of chronic opioid use in this report, also used by some states such as Washington in their guidelines. Some injured workers who were prescribed opioids also concurrently received other central nervous system depressant drugs. CDC guidelines recommend that practitioners avoid prescribing opioids and benzodiazepines together when possible due to heightened risk of potentially fatal overdoses. At least 1 in 15 injured workers prescribed opioids in 3 states, Massachusetts, Louisiana, and Wisconsin, filled a benzodiazepine prescription within 1 week of the opioid fill. In contrast, the rate was less than 1% in Texas, where pre-authorization is required for such a prescription. Next, I will describe some of the more prominent policies implemented by workers' compensation jurisdictions, or more broadly at the state level, that address opioid prescribing and dispensing. First, as of late 2017, 16 states have treatment guidelines for opioid prescribing or chronic pain management. These states developed state-specific guidelines or used nationally recognized guidelines for occupational injuries. Several guidelines, including the CDC guidelines for prescribing opioids for chronic pain, caution prescribers to reassess the risk and benefits to patients when prescribing an opioid daily dose exceeding 50 milligrams and to avoid an opioid daily dose exceeding 90 milligrams. The 2016 CDC guidelines for prescribing opioids for chronic pain note that for acute pain, 3 days or less is sufficient and more than 7 days is rarely needed. Second, 15 states have implemented or passed legislation to implement a drug formulary. Drug formularies have different elements. For example, pre-authorization for specific drugs, or whether the recommendations are tied to conditions. Third, 8 states have quantity limits on physician dispensing of opioids. Florida and Kentucky enacted legislation limiting physician dispensing of certain opioids. Pennsylvania and North Carolina limit workers' compensation reimbursement of opioids to a certain number of days. It is important to note that some states prohibit physician dispensing generally unless there are unusual circumstances or access issues due to rural locations. Fourth, at the end of last year, 21 states had implemented limits on the number of days for the initial prescription of an opioid. Fifth, all states have passed legislation implementing prescription drug monitoring programs, or PDMPs. The PDMPs have varying features. 39 states mandate prescribers to query the PDMP before prescribing certain controlled substances, at least for the first time. In states like Kentucky and New York that were early adopters of PDMP prescriber mandates, our data show large decreases in opioids dispensed to injured workers. Finally, the medical boards of many states have mandated continuing medical education on appropriate opioid prescribing and chronic pain management. Thank you to the subcommittee for this opportunity to share our research findings, and I look forward to addressing your questions.
Thank you, Ms. Tanabe. Mr. Peduto, you are now recognized for 5 minutes.
Good morning, Chairman Byrne, Ranking Member DeSaulnier, and distinguished members of the subcommittee. My name is Joe Peduto. I'm the president of Comp Pharma, LLC. We're a consortium of workers' compensation pharmacy benefit managers. I have 34 years experience in medical management areas and workers' comp with a specific expertise in workers' compensation pharmacy. Helen Knight and I founded Comp Pharma 16 years ago to research pharmacy issues in the workers' compensation space and advocate for solutions to drug issues in workers' comp. Our focus is really on patient safety, and it's on the effective use of evidence-based guidelines. I work with regulators, large insurers and employers, state funds, claims administrators, and state governments related to issues surrounding pharmacy. Excuse me. Over a decade ago, workers' compensation payers began to recognize the opioid issue. They noticed that injured workers were getting opioids for simple back strains, which is wildly inappropriate given the prescribing guidelines from the FDA. Folks with opioids had longer durations of disability, and those patients could not work while recovering due to opioids. You do not want somebody taking opioids, teaching your children, or driving a school bus, or operating the forklift. They saw indications of diversion and evidence of patient deaths associated with opioid prescriptions. Since then, the industry has made great strides. Comp Pharma's latest data indicates the workers' comp industry has reduced opioid spend by over 1/3 in the last 2 years alone, and by over half over the last 5 years. Unfortunately, when it comes to dealing with the opioid crisis, the Federal Employee Compensation Act and administrators are 5 or 6 years behind the rest of the workers' comp industry, and time is running out for patients who've been taking opioids over an extended period of time. The DFEC's initial effort at opioid controls are far too permissive and wildly inconsistent with all credible opioid guidelines. Prescribers are allowed to prescribe 2 different opioids at unlimited dosage for up to 60 days. As Ramona just indicated, that's considerably inconsistent with all state guidelines, especially ones that are evidence-based. Most guidelines allow no more than 7 days, and then only if prescribing meets stringent tests. Specific examples of governmental agencies making great strides include Ohio under Governor Kasich's strong leadership. The state has seen the number of opioid-dependent injured workers in the Bureau of Workers' Compensation fall by 19% last year alone, and that was the 6th year of significant decline. After 6 years of smart policy and tireless efforts, there are 4,700 fewer workers at risk for addiction, overdose, and death, thanks to the efforts of the pharmacy program directors, first John Hanna and now Nick Trago, the medical directors and administrators at BWC. This reduction in opioid use will also save employers and taxpayers millions of dollars in Ohio. Washington State Fund has been the leader in fighting opioid misuse. Working with other state agencies, Dr. Gary Franklin and Dr. Jamie Mai have been instrumental in reducing opioid usage. Today, less than 4% of drug spend in the state of Washington workers' comp is for opioids. Since 2014, California State Compensation Insurance Fund has reduced the number of opioid scripts by 60% and reduced the number of patients taking high levels of opioids from 1,458 to 186. As a state-regulated industry, workers' comp has shown us what works and what is not effective. It's taken FECA far too long to even begin to address the opioid crisis. Then, the policy of allowing 60 days of 2 different opioids is wildly inconsistent with all credible guidelines. FECA must move now to build an approach to prevent further needless deaths among its 27,000 chronic opioid-using patients. This should include random drug screening for all patients prescribed opioids, not to be confused with pre-employment or employment drug testing, require prescribers utilize written screening tools, require opioid agreements signed by the prescriber and patient, require documentation of changes in functionality and pain, and for chronic users, understand each patient is unique. I'll close with this. Some may be concerned that FECA or its PBM will try to replace physicians' decision-making authority. Physicians want to do the right thing. Getting their patients off opioids is absolutely the right thing. And physicians often don't have the training, education, tools, or understanding to do this. It is FECA's job to provide that education, training, and guidance. Thank you for listening and for taking action.
Thank you, Mr. Peduto. Mr. Dahl, you're recognized for 5 minutes.
Good morning. In one of our ongoing criminal investigations, a pharmacist billed the FECA program $29,000 for a single 15-ounce prescription of compounded cream. That was actually not medically necessary, allegedly. Mr. Chairman, that's smaller than the size of this coffee cup. In a separate investigation, 3 pharmacists were convicted of paying over $6 million in kickbacks to a doctor for him and his associates to prescribe compounded drugs to be filled by these pharmacists. As a result of this fraud, the FECA program paid $15 million for compounded drugs, including pain creams. This is just a few examples. These are a few examples of the work illustrating that the FECA program is susceptible to fraud, waste, and abuse, particularly in the pharmaceutical part of the program. Since 2008, the OIG has opened over 750 criminal investigations involving the FECA program, leading to the conviction of over 400 individuals, including nearly 100 convictions from medical provider cases, and producing more than $270 million in monetary results. OIG investigations have uncovered a variety of schemes, from payments for billing for services not rendered or necessary to complex kickback schemes. Medical provider fraud, like the cases I mentioned, represents the greatest risk to the program because of the substantial amount of money involved and the potential harm to injured workers' health. In the last 18 months, following recommendations from my office and others, the department significantly reduced payments for compounded drugs by requiring letters of medical necessity for compounded drugs signed by the doctors and also prior approval from the FICA program. However, FICA did not take significant and timely action to address this astronomical rise in costs of compounded drugs. And now close to $600 million has been paid out for these drugs over the last 5 years. Certainly not all of these payments were fraudulent, but the sharp decline in costs following the implementation of controls calls into question whether past billings were for medically necessary or otherwise legitimate treatments. I have no doubt that the OIG will continue to investigate fraud schemes involving compounded drugs for at least several more years. Moreover, fraudsters will always find new and creative ways to defraud benefit programs. Mr. Chairman, we are seeing another disturbing trend in the FICA drug program, and this one involves opioids. Allegations include the overprescription and illegal distribution of opioids. This has become a top priority for my office, and we are working closely with our law enforcement partners to combat fraudulent activities like this that threaten the integrity of the FICA program and potentially harm the injured workers we are trying to help. To better address these fraudulent activities, the OIG is strengthening its data analytics capabilities. Using risk fraud factors from our investigations, we have assigned scores to almost 100,000 medical providers. These capabilities allow us to proactively investigate providers who pose a higher risk of fraud. The OIG is also referring FICA medical providers who commit fraud to DOL suspension debarment official so that these providers can no longer receive federal funds. In addition, we have referred medical providers to state regulatory authorities so that they can take administrative action against these providers, including revocation of medical licenses when appropriate. As part of our current review of pharmaceutical management at DOL, we are evaluating how the department is addressing the use of opioids. Our preliminary analysis of DOL data shows that more than half of FICA's monthly pharmacy claims include opioid prescriptions. Let me repeat that. More than half are for opioids. Mr. Chairman, thank you for the opportunity to testify and for this committee's continued support for the work of the OIG.
Thank you, Mr. Dahl. Each of your testimony was superb and very helpful to the committee. We're now going to have member questions. As I said earlier, they'll be limited to 5 minutes. We are honored today to have the chairwoman of the full committee, Dr. Fox, a gentlelady from North Carolina. We'll begin questioning with her. 5 minutes. Dr. Fox.
Thank you very much, Mr. Chairman, and I want to join the chairman in thanking all of you for coming today and presenting some really riveting testimony to us that's very enlightening in terms of particularly some of the numbers that you've given us. Mr. Dahl, you referenced in your testimony that your office is strengthening its data analytics capabilities to improve the review of information in FICA's database. Could you elaborate on this a little bit on how the updated system will help detect fraudulent activities taking place in the FICA program? And will what you're doing allow for earlier detection before they result in fraudulent billing?
Thank you, Chairman Fox. Yes, as I mentioned, we have taken the list of medical providers from the FICA program, about 100,000 of them, and assign risk scores to them so that we can better target our investigations to go after the ones who are most likely to defraud the program. And this is, leading us to be able to be more proactive about finding the ones that where there are significant anomalies in the billing system. Likewise, the OWC's Program Integrity Unit has these same data analytics capabilities, and they are using those capabilities now to do just what you're talking about, and they should do more of that to proactively detect the problem billings and screen them, and then before they go out, and then cut them off if they find problems afterwards, and then also use that data to fix some of the systemic problems that are causing these this vulnerability to fraud.
Thank you very much. Ms. Tanabe, in your testimony, you note that your study found there's a fourfold variation in the average amount of opioid prescriptions filled by injured workers across 26 states. Are there certain geographical regions in the country where injured workers are more likely to receive an opioid prescription for their work-related injuries? And do you see any variation between rural and urban areas?
Thank you, Chairman Fox. We have not done any studies on rural versus urban geographic differences of the frequency of opioid utilization. Neither do we see any patterns of high opioid utilization versus low opioid utilization across the United States.
Thank you very much. Dr. Simandaro, I would welcome additional comments about the chargeback process for FICA payments to beneficiaries. We've heard a lot about fraud and abuse in the FICA program. Does the chargeback process reduce the incentives for appropriated agencies to ensure their employees are not filing fraudulent claims?
Well, thank you. While initial benefits under FICA are paid from the Employees' Compensation Fund, which is financed by appropriations to the Department of Labor, the Department of Labor then bills each employee's host agency for the cost related to that employee's claims. That is a process called chargeback. I think in theory, this provides an incentive for each agency to provide a safe workplace to prevent injuries, and then to try and work with OWCP, with their own human resources staff, to get injured workers back to work, because every dollar that that worker is receiving in FICA benefits is ultimately being paid by that agency. In the case of certain non-appropriated fund instrumentalities, such as the Postal Service, they also pay an additional fee for the fair share cost of administration. So that's added on to that. But for agencies, the chargeback process, in theory, should give those agencies an incentive, as every agency wants to spend its budget wisely, to reduce work injuries and return workers back to work, thus reducing their chargeback costs.
Thank you very much. I yield back, Mr. Chairman.
Thank you, Dr. Fox. We're also honored today to have the ranking member of the full committee, the gentleman from Virginia, Mr. Scott, who's recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Dahl, some of these compounds that you referred to seem so absurd that you wonder how the check could have been written to pay the bill. When a bill comes in for $30,000 for one little treatment thing, didn't anybody say, what's up with this?
Well, I'm sure that there's a mechanism that the FICA program has, and they did actually reduce the reimbursement for that. But as the Congressman knows, the FICA program is structured in a way that if there is a doctor's prescription, a doctor's order for the medication, that the FICA program by default pays for that.
Well, has any other program been hit by these kinds of attacks?
Yes, and maybe alluding to obviously the Medicare and the Medicaid program and the TRICARE program on the Department of Defense side have been hit with these several years ago, and really put controls in place to stem the rise of those costs several years ago, and OWCP is learning from some of those measures, including using letters of medical necessity.
Well, how does a prescription get filled unless somebody along the line certified that there was some medical necessity?
Well, that was the...
Or is that a new thing?
That is a new thing now. That's since 2016.
I mean, you were filling prescriptions without somebody in the chain certifying that there was some medical necessity?
That's correct. That's now a requirement.
How did the prescription get out of the doctor's office without a certification, or at least a representation that it was medically necessary?
I think that's incumbent upon that doctor to do that, but the certification for the FICA program has only been required for compounded drugs since 2016.
Has anybody looked at the licensing procedure when prescriptions come out of a doctor's office prescribing things that are clearly not medically necessary, or the pharmacy license to fill a prescription that is absurd and overpriced as $30,000 for something that provides no apparent benefit?
You know, it's interesting because I think that's, as I mentioned in my testimony, an area that we're focusing on now is to ensuring that the regulatory authorities are aware of the fraudulent convictions that we have so that the licensing authorities can take appropriate action.
Even before the conviction, did you ever just mail some of these things to the medical board and say, just wanted to let you know what some of your doctors are prescribing?
We haven't done that yet, but it's certainly something that the program should consider as they're providing management of the program is what sort of communications there could be with the licensing authorities.
And the pharmacy, I mean, they have their license. Just mail it to the regulatory board and say, you know what your pharmacists are filling and billing government agencies tens of thousands of dollars. Did you know this? Has that ever been done?
I don't think it's been done yet, but that's certainly something that OWCP could consider as a possible remedy to address this area.
$30,000 for one tube of stuff. How do you make up a price?
Well, that's a very difficult question. I think we've looked at the component ingredients of many of these compounded drugs and determined that the actual cost is a fraction of what the program is charged, and that's part of the problem with it.
So, I mean, do they get to just make up a number and somebody just writes a check?
Well, right now there are not price controls in place for the FICA program, as there are for other programs.
Thank you, Mr. Chairman.
Thank you, Mr. Scott, for your very insightful questions. I will now recognize myself for 5 minutes. Ms. Tanabe, according to a study by the National Safety Council, 33% of respondents did not realize they were taking or had taken an opioid. They only recognized the opioid by its brand name. When it comes to drug compounding, many opioids and other medications may be mixed together to create a prescription for the individual patient. In light of the opioid epidemic, what steps could be taken to ensure patients have a greater understanding that they are taking a compounded drug for their work-related injury that contains one or more ingredients that are opioids?
Thank you, Chairman. Several states have implemented patient awareness programs so that patients are made aware of the choices of the drugs that they're being prescribed, and that includes notifying them of opioids in the drugs.
Let me follow up on that for a second, and this somewhere comes off of Mr. Scott's questioning. Isn't there an obligation on behalf of the physician to inform his patient about what there's being prescribed and what that drug could be doing to them?
I'm not aware of any requirements within the states that they have such a requirement to inform injured workers, in this case, of what they're taking.
Yeah, I didn't phrase that question very well. I'm really thinking more in terms of what is the professional obligation by a physician based upon their licensing boards around the nation. Is there any sort of requirement that physicians actually inform their patients as to what they're being prescribed and what it could be doing to them?
I'm not aware of any requirements in the states for that.
I think that's a very interesting area to follow up on as well. Mr. Dahl, as more FECA beneficiaries need treatment for their work-related opioid addiction, what should be done to ensure the services being provided are in the best interest of the beneficiary and will help the individual to recover from his or her opioid addiction? Do you believe this is ripe for fraud and abuse as well at the expense of the injured worker?
Thank you, Chairman Byrne. What the best treatment is for the beneficiaries, I leave to medical experts. But the FECA program should put controls in place to ensure that the treatment for these opioid recipients is effective and medically necessary. And we're evaluating those controls right now in our current audit that we have ongoing.
So going back to Mr. Scott's points, so we have a government agency telling a doctor, medical professional, hey, what you're doing may not be good for your patient. The federal government has to tell a medical professional that?
Yeah, this is the difficulty in the government getting involved in the medical treatment of patients and beneficiaries. And as we saw in the compounding area and as we're seeing in opioids, it appears that some doctors are motivated by other things than what's in the best interest of their patients. And so we just want to make sure that the program is not only aware of that, but is taking active measures to enforce those kinds of requirements.
And I know you're not saying this, and I don't want to be heard to say this, that I'm trying to paint a broad brush across the medical profession, because we have the vast majority of our physicians in America are very, very conscious of their obligations to their patients, but obviously we have cases where they weren't, and that's disturbing from not just a FECA perspective, but from a general perspective. Dr. Simondera, you mentioned that the general policy of the FECA program is to give deference to the treating physician. However, for certain prescriptions, the Department of Labor now requires authorization based on this letter of medical necessity. What information must the letter of necessity include, and how does the provision of this information factor into the agency's review of the prescription?
Thank you. The letter of medical necessity requirement is reviewed. The letter of medical necessity from the physician, is required to show why this particular treatment is necessary for the particular condition that FECA is paying benefits on. It's reviewed by the claims examiner at OWCP. The claims examiner, who's not a physician but a federal employee, can seek the assistance of the district medical advisor, who is a physician, staff nurse, field nurse, or in the medical field, can also recommend a second opinion medical exam to verify that information that is in the letter, to ultimately make the decision whether or not the continued prescription of an opioid meets that statutory requirement that's in the FECA statute, that we're not paying for just any medical coverage. We're only paying for medical coverage likely to cure, give relief, or reduce the amount of benefits by assisting in returning the worker back to the workplace.
Thank you, Dr. Simondera. I now call on the gentleman from New Jersey, the gentleman, Mr. Norcross, for 5 minutes.
Thank you, Chairman and Ranking Member, and certainly the witnesses for having this extremely important discussion. I'm Vice Chair of the Heroin Task Force, which is dealing with many of the issues we're talking about today. But the basis for all of this is the disease of addiction. And I've been hearing from many of the witnesses and certainly the questions following some of the cost issues that are involved or following the money. We need to remember that we should be following the lives that are impacted, the people that are dying from this disease, not only the money. In fact, I would suggest it's much more important, which leads me to the first question. Mr. Simondera, how many overdose deaths are there a year on those on workers' comp?
Congressman Norcross, I don't have that information readily available. I certainly can.
Do they track it?
Well, it's important to understand when we talk about workers' compensation, there is no federal oversight of state workers' compensation programs. The vast majority of workers in this country are covered by a state program.
I understand. I'm talking about the program we're dealing with.
Just within FECA.
That's all I'm asking about.
I have not seen data on overdoses or overdose deaths within the FECA program specifically. That's information that would have to come from the Department of Labor. They would track those they could, in theory, track those outcomes.
Do you know
if
they track them?
I don't know if they do.
But they track certainly the dollar values that we're chasing here today, and that's one of the points. If somebody, and I'm not sure if this would go directly to you, if there is a person who's being treated workplace injury, broke his leg, get an opiate, and then becomes addicted to that, is that considered a workers' comp claim?
Yes. The FECA procedure manual specifically permits up to 28 days of inpatient treatment for a substance abuse disorder that is the result of treatment for a workplace injury.
Do we track that?
Again, that would have to come from the Department of Labor.
But do you know if we track that?
I don't know.
Does anybody know if we track those? So what we're hearing here is that there are overdoses that take place, there are deaths that take place, there's treatment that takes place, but we don't know it. Does anybody have any information? Please.
It's very difficult to track deaths due to or associated with opioid prescribing because the death certificate may or may not reference the specific cause of death, and the opioid may have been prescribed outside of the workers' compensation system, or there may be another drug. When the state of Washington looked at this about 10 years ago, they determined that the number of deaths that actually occurred due to opioid use, or as Ms. Tanabe noted, complications due to benzodiazepines and others combined with opioids, was much higher than they originally thought. So the problem is that there's a lack of data on the front end and data consistency in coroner's reports that would be used to ascertain the cause of death.
We agree. There's underreporting in excess of 20%. 65,000 people died of the overdose. There are predictions that it was closer to 80,000, 75 to 80,000. So that's a problem. But what is readily available are those who become addicted. And certainly we need to track the human side of that, because there goes the cost. And following up with our ranking member's question is, this is something that is happening. It's going on a daily basis, and we're not tracking it. But we are tracking the money. I think we have to track the human side of this also, and I yield back the balance of my time.
Thank you, Mr. Norcross. The chair now recognizes the gentle lady from New York, Ms. Stefanik, for 5 minutes.
Thank you, Mr. Chairman. This is an incredibly important issue in a district like mine. I represent New York's 21st district, and one of our largest employers is the federal government when you consider the northern border, employees at the VA, or employees at Fort Drum. My first question is for Mr. Dahl. In your testimony, you stated that in 2008, that since 2008, your office has opened more than 750 criminal investigations involving the FECA program. How much time do these investigations typically take before they're completed? And then my second part of the question is, given limited resources, how do you decide which cases to investigate?
Thank you. Let me break this up into two quick answers. There's the claimant side of this, the beneficiary side. Those cases are pretty straightforward, and they don't take usually longer than a year. And many of those are handled by the OIG from the affected agency. Except if they're, it's a smaller OIG, then we might assist them, and particularly in getting data from OWCP. We've shifted our attention to the medical provider side because of the greater harm to the program, and we started doing that about 4 years ago. And those cases are more complex, involve multiple parties, sophisticated means, sometimes conspiracies, and they may take 2 years or longer to complete. And because of the resource issue that you alluded to, we have teamed with our law enforcement partners from other agencies that are affected by this. They include Postal OIG, VA OIG, HHS OIG, and others to investigate these matters because we don't alone have the resources to do that.
Another question I had, you mentioned in your testimony that one of the updates that was made is requiring letters of medical necessity. What other best practices and programmatic changes do we need to take to reduce fraud and abuse in the FECA program?
Well, I think that I just go back to Chairwoman Fox's question about using data analytics, both by the OIG and the program itself. And I think that those can be early warning signals that they did not see for compounded drugs. So they can get on top of this, because we all know that fraudsters are not going to stop defrauding a program because we've shut off one spigot. They'll find another place to hit us. And so we have to be vigilant in using data analytics tools to tell us when that's occurring, and putting in place, the program putting in place measures at the front end to prevent the fraud from occurring so that we're not having to investigate it on the back end.
Thank you, Mr. Dahl. My last question is for Ms. Tanabe. You note in your testimony that at least 1 in 15 injured workers in Massachusetts, Louisiana, and Wisconsin filled prescriptions for central nervous system depressant drugs within 1 week of an opioid prescription, and that the rate of these prescriptions was even higher among claimants receiving opioids on a chronic basis. Do you think we need to further focus on the effect that opioid prescriptions may have on individuals' mental health in addition to addiction?
Thank you. It's not clear that from the data that the benzodiazepine prescriptions were prescribed for mental health conditions that resulted from the opioid prescribing. They may have been prescribed for already existing mental health conditions, comorbidities, or even for muscle relaxants. Much of the prescribing for that we see in the data are for cyclobenzaprines, which is a muscle relaxant. Many treatment guidelines recommend an initial assessment of a history of the patient's substance abuse disorders and mental health condition before initiating chronic opioid treatment because of the risks that are involved in chronic opioid treatment. So it's important for future research to look for insights on chronic pain management by studying opioid prescribing for people with mental health comorbidities.
Thank you. My time's expired.
Thank you, Mr. Stefanik. Chair now recognizes for 5 minutes the gentleman from California, Mr. Desanier.
Thank you, Mr. Chairman. These are difficult discussions and frustrating for all of us. The number I always remember is the U.S. has less than 5% of the world population, but we consume over 80% of the painkillers in the world. And that implies that the people who have made money off of this, whether it's organized crime or illicit drug folks or pharmaceutical industries, have been pretty sophisticated at making money off of this. So Mr. Peduto, you said that the feds are 5 or 6 years behind, and you also said that it's taken FECA far too long, quote unquote. FECA must act now. So to you and maybe Ms. Tanabe, why is it that other states like Washington have been able to effectuate change, and we're still having this discussion while we're losing millions of dollars and people are absorbing unbelievable suffering?
I think it's a failure to recognize the depth and significance of the problem, sir. Washington recognized that when Dr. Gary Franklin first started looking at deaths and then tracked back and figured out that these were opioid and complications of opioids and other medications. I think, as Mr. Dahl has mentioned, data analytics plays a big part. With that said, I think the challenge that we have in the workers' compensation for OWCP is they're taking some initial and very minor steps to address not digging the hole any deeper. However, when you allow 60 days of double opioids at unlimited dosage, you could have someone taking 1,000 morphine equivalents, which could be 8 or 9 OxyContin pills a day, plus other types of medication. So that really does not go nearly as far as it should to stop us from creating additional harm, devastating additional families. But we also need to really look at what do we do about the long-term users, as the state of Washington has done, as California has done. So again, from an analytic perspective, I think it is incumbent upon the OWCP et al. To really look and examine how many patients are chronic opioid users, and let's use a standard for that of about 50 morphine equivalents for more than 60 days, because those are the patients where there's an inflection point that the risk of dependency or addiction goes up dramatically, and then it escalates from there. So the first thing is to look at the analytics and figure out what the problem is, and unfortunately that doesn't appear to have been done yet, unlike what's happened in the rest of the world.
Ms. Tanabe, you have any insight?
Many of the states have put tools in place to monitor different issues that come up with opioids, and FECA has taken steps towards limiting the opioid first fills. For most of the states that put a limit on the opioids, the amount is 7 days or less for an opioid fill. So there are many lessons to be learned from states, and they've taken them incrementally. One of the recent phenomenon is that reimbursement for recovery and rehabilitation programs. Many states offer that now, and offer guidelines include information on weaning off of opioids as well.
Mr. Dale, your risk fraud factors, I find that very interesting. So these doctors, the prescribers, do some level of risk assessment when they decide to do such things that are unethical, as the chair has implied. It reminds me of their original oath, if you're a physician, first do no harm, as opposed to first make a lot of money. So on these risk factors, what are the disincentives, given that there's so much incentive apparently for people, some people unfortunately, to game the system? Are they held personally responsible? I know in California we struggle with a licensing board that was loath, and I think it's changed under this governor, to actually discipline some of their colleagues. There was a cultural problem there.
I think that this deterrence factor is so important, and that criminal investigations that we're doing are having real-world results, and it's getting the word out that some of these are, doctors are they're being escorted out of their offices with a perp walk and showing up in the news and ultimately being convicted for this kind of fraud. And I think that is spreading, and I think that, as you mentioned, the regulatory boards appear to be more receptive to yanking their licenses when they've been convicted of these crimes.
And are you collaborating with state agencies and local district attorneys to the degree that you can statutorily?
Yes, we do. We work with local and state authorities in our cases. In some cases, they do involve state programs.
Thank you. Thank you, Mr. Chairman.
Thank you, Mr. Desaulniers. The chair now recognizes the gentleman from Georgia, Dr. Ferguson, for 5 minutes.
Thank you, Mr. Chairman, and I'd like to thank each of you for being here. And let me just say, this has been an eye-opening conversation, and I applaud the efforts to really crack down on the bad actors that are in this system, no matter where they are. But I want to talk to you a little, and have a conversation a little bit from the perspective of a healthcare provider as well. You know, I find it interesting that in this conversation, there's an awful lot of talk about the opioid prescriptions, but we really never really talk about why they are prescribed in the first place, okay? And I think that they are completely overprescribed, and I can tell you, as someone who had a dental practice that used to do a lot of oral surgery, you have to recognize the difference between pain and nociception. And nociception is the body's noxious reaction to a noxious stimulus, and pain is the emotional component that goes along with it. And you should be able to deal with the things that start the pain process. The problem lies in when you start prescribing opioids, you're prescribing something that deals with the emotion of the traumatic surgical event. The longer those things go on, the more problems that you're going to create, period. I've seen it in practice. I've seen it with my patients, whether they're coming from other practices, and watching what happens when they have a lower back pain and a physician prescribes them 60 days of a narcotic. You have just created an addict, period. It happens. And so we've got to, as a part of this conversation, I think it's really important that we talk about alternative treatments, and we quite candidly look at how physicians and prescribers are reimbursed in this arena as well. We talked about, had a good comment about, you know, what's the financial incentive to do this. The reality is that when physicians aren't reimbursed for post-operative care, and rehab is not, and rehabilitative services for injuries are not reimbursed at a fair rate, there's every financial incentive for a physician to prescribe 30 to 60 days worth of drugs so that the patient simply won't come back and eat up chair time because the reimbursement rates are so low for other procedures. You just don't have the capacity in the practice to do that. So I really want to focus on making sure that we're looking at alternative treatments to move as far away from long-term opioid prescriptions. Mr. Dahl, thank you so much for your efforts to go after and prosecute. I think to prosecute on financial fraud is one thing, but when you consistently do that, you're in essence destroying the lives of not only an individual and a family, but I will tell you that there needs to be more than just simply a financial component to this as well. This is creating actual harm to patients, and we need to go after the bad actors. One last thing, I want to say this before I ask a question. Actually, ask a question on on alternative treatments. You know, I would be very wary of creating new rules to go after the very worst offenders. And having those really hinder the good apples in the bunch as well. I can tell you as a healthcare provider that every time you go after the bad, you know, the 10% that's violating the rules, the 5% or whatever that number is, be very careful about swinging the pendulum so far to one side that you create hurdles for people trying to do the right thing every single day in there. So don't overfix the problem. Let's find out where that balance is. Let's go after the bad apples. Let's take the bark off of them. Go do what you have to on them, but don't make it so cumbersome that the good providers out there are restricted in their ability to care for patients. So with a minute left, Ms. Tanabe, can you talk about alternative treatments and how important that is and to begin to build that culture?
Yes, thank you. Massachusetts actually has put in place a program that's in line with the recovery and rehabilitation. It's a voluntary program for claims that have settled, but where the injured worker is still receiving opioid prescriptions. They're given a care coordinator to guide them towards alternative treatments. And there are other states that have similar programs. Ohio is one, as well as Washington State.
Mr. Chairman, in my last 10 seconds, you asked an important question earlier about do we have to have the federal government have a rule to tell physicians to tell their patients about the harms and damages of opioids? I will tell you that you don't need the federal government to do it. The malpractice environment is rich, and I've said, you've heard me say this before, right up there with IRS or plaintiffs' attorneys and OSHA as a healthcare provider. Those are the things that I worry about and try to prevent harm to myself on.
Thank you, Dr. Ferguson. I think we should have included you as one of the panel members, but we certainly appreciate your insights, and you were one of the people I was talking about earlier when I said we should not paint with too broad a brush. So thank you for your very enlightening remarks. The chair now recognizes Ms. Shea Porter for 5 minutes.
Thank you very much, and thank you for being here. I represent New Hampshire's 1st District, and the state of New Hampshire has really struggled with deaths and abuse of these drugs, so we're all deeply concerned here. I want to start, Mr. Dahl, I wondered when you said that there's no price controls for prescription drugs. And did I understand you correctly? You were talking about that compound that was, what, $30-something thousand, and we were all wondering how that could have gone through. But has any action been taken at all? I mean, what happens when they come in with these outrageous bills there? It seems like this has been a pattern for a long time. So I'd like you to add a little bit of information for us to understand.
The OWCP does have a reimbursement schedule that they have for drugs that come in, and so the one I referred to earlier, they did reduce that when they paid out paid the claim on that, but they don't have. OWCP right now is not focusing on what a fair price is for the drugs, and it's something that we've suggested that they spend more time on. Their abilities to refer to a ceiling price for drugs is not available to them right now under the law, as it is, as I mentioned, as it is for other programs, and that's something that we've recommended be changed through legislation.
So that's the only way that this can be solved, is what you're saying? This has to be done through legislation? Well,
I think that there are other mechanisms short of legislation that the department could be doing. As I said, focusing in on establishing what they would determine a fair price would be for certain drugs, short of legislation, because there are things that the department has been and can be doing to address that issue.
Well, that's what I thought. So what do you think the problem is? Why isn't this happening?
Well, I think that part of the problem is that that the way that the FICA program was structured and set up, and the culture, the legacy culture, is that when a doctor or a prescriber orders certain treatment or medication, that the program pays for that by default, and there aren't enough controls in place to prevent the kinds of things that we were seeing with compounded drugs and with opioids.
Because I know in other agencies they've had a handle on drug costs, so it seems bizarre to me that they have not been able to do that yet, but I appreciate your sharing that. I also wondered, I was listening to the comments that it's not an obligation for a physician to tell a patient, and I heard my colleague say, if I understood him correctly, that that's malpractice. If they're acutely aware, they don't need the federal government to tell them that. And yet, it seemed like the statistics show that people don't really know that they're taking an opioid. Could you confirm that, please? I think, didn't that come from one of you here saying that there is not a obligation to tell people that they're taking an opioid, and that a lot of them actually don't know?
Thank you. I'm not aware that there's an obligation. The WCRI has not done any research in the areas of what physicians are and aren't obligated to tell injured workers.
But there is a number of people who actually don't know they're taking it that's been prescribed to them.
I'm not aware of that, but.
And that's a great worry. People need to actually know. I think part of the problem has been that we haven't focused on prevention, that we haven't educated enough so when people are taking a prescription and it's been given to them by a physician, they don't question because they don't feel they have the knowledge to ask. So would anybody like to comment on changing that culture?
I think you raise an excellent point. What's happened in the commercial workers' compensation world and among state funds is they have tasked their pharmacy benefit managers with notifying patients who have been prescribed opioids immediately via phone, and then with follow-up documentation describing what some of the issues may be. There's also outreach to the prescribing physician. They also seek to use prescription drug monitoring programs to ascertain if those patients are taking opioids from other sources besides workers' compensation, along with benzodiazepines, muscle relaxants, et cetera. So it would make a lot of sense if OWCP put in place some sort of educational program where there would be outreach to the prescriber, asking that prescriber to make sure that they provide education, as well as outreach to the patient and potentially even the patient's family, if that's allowed, to let them know of the risks inherent in opioids. That is a short-term way that could make that happen relatively quickly, and then engage that patient in a discussion with some of the risk factors involved.
Thank you. That really would not be a burden on anybody to take that step to make sure that a patient's informed before taking any prescription drugs. So I appreciate your comment, and I only have a little bit of time left, but I wanted to ask each one of you.
Ms. Shea Porter, you really don't have any time left, so if you can make it go very quickly.
Okay, all right, I'm looking at my clock and you're right, but I just wanted to know, is there anything that we didn't ask that is standing out and you were hoping that somebody on this panel would say?
Yes. The issue with letters of medical necessity presupposes that there's clinical evidence that backs up a determination around is that medically necessary or not. So you can have a process that says you have to submit a letter justifying it, but then what is the standard of evidence that says, yes, this is okay, or no, it is not? Without that evidence-based clinical guidelines in place, you have OWCP making ad hoc one-off decisions that might be inconsistent across the entire OWCP patient population. So I would strongly encourage the committee to really drill into what evidence-based clinical guidelines are appropriate for prescribing and allowing opioid use, both initial and over the long term. That way you would have a standard that you could promulgate and publish and educate prescribing physicians around, and then they would have to take specific steps to determine or to justify, if you will, going outside of those, which I think gets to Dr. Ferguson's point is you don't want to have a policy in place that has a deleterious effect on all the prescribers. What that would do is the prescribers who are doing things consistent with good medical practice are fine. They don't have any issues. The ones who are going outside, and there may very well be good reasons for that, those folks have to explain themselves.
Thank you. Thank you for your indulgence.
Thank you, Ms. Shea Porter. The chair now calls on the gentleman from Wisconsin, Mr. Grothman, recognized for 5 minutes.
Yeah, just perusing some of the testimony, Mr. Peduto, you mentioned just in passing here that the Department of Defense spends 34% of its medical costs on drugs, which seems kind of high. Could you compare that to other agencies or other private sector groups?
Yes, sir. The average spend in the commercial space for state governments and for state funds is between 9 and 12% of medical costs are for drugs, and about the latest data we have is about 22.5% of drug spend is for opioids. DOD's spend does appear to be significantly higher than other federal agencies, but the data is inconsistent, and I'm not comfortable with making a characterization as the numbers seem to vary.
You think that's a good number, though, when you tell us 34%?
No, I think that's a horrible number, sir.
I mean, but is it a number we can count on? You'd stand behind that number.
I have no idea because the data collection is, I'm not familiar with that.
It's just in your testimony, but you're saying it might not be true?
34%, that's what DOD represents.
Okay.
That's their number.
Okay, well, that's kind of alarming. Maybe we should look at that later. FECA, their spending is up 161% in 5 years. Could someone comment on that compared to medical costs in this country in general or whatever? That's what we're told.
Medical costs in the workers' compensation space have been increasing around.
As I understand, this prescription drug costs went up 161%.
Prescription drug costs, sir? In the workers' compensation space, prescription drug costs are down about 22% over the last 5 years in the commercial space.
Okay, so in other words, this is another example of the government being way out of whack with where the rest of the world is, right?
Yes, sir.
Okay, CMS has been recommending first prescription for opiates 7 days and second prescription 30 days. Could somebody comment on that, or why we aren't aiming for that as the target for federal employees?
I think there's a lot of good clinical evidence that supports that, and a number of the guidelines, including the ones I think are probably the best out of Washington State, certainly support that.
Okay, why are we not aiming for that then for our federal employees? Does someone have a comment on that, one way or the other? The other three don't have a comment? I guess not. You want to take a stab at it?
Congressman, I would just point out that the FICA guidelines were issued by the Department of Labor. It's not a legislative mandate, nor was it even through the regulatory process. It was a guidance that was given by the Department of Labor. So, I certainly can't comment on why the Department of Labor made the decision to go with 60 days versus other versus another number.
I guess the point I'm trying to point out is it's way out of whack with what's going on in the rest of the world, right? And it probably results in financial costs to the taxpayer, and secondly, probably has far more opiates floating around our society than necessary, right?
It is, as Mr. Peduto has said, it is inconsistent with what states are doing. It is also inconsistent with what CVS Caremark, one of the larger retail providers, which has put a 7-day limit on initial opioid fills. Walmart, my understanding is, has recently, I think as recently as this week, announced they're going to go to a 7-day limit. So it is also inconsistent with what in this case, 2 large retail pharmacy chains have adopted as their own practice.
Always nice people at Walmart looking out for society. Yeah, we're so out of whack here, it's kind of hard to believe. I'll give one more question with regard to you folks. Do you think a lot of these are prescribed for back pain or leading to surgery? Do you think? Anybody comment on that? Yes, you may comment. Sure.
The studies that WCRI has put out, we exclude surgical claims because most of those claims get at least one prescription for a pain medicine. So when we look at that, the percentages that we see of the number of injured workers that received opioid prescriptions are relatively high, again, with a 4-fold discrepancy across the states.
I guess what I'm trying to get to, there are different things you can do with back surgeries. Some are more effective than others. Are you familiar with that at all, or new products on the market that may significantly decrease the amount of pain?
Yes, sir. There's some recent research that came out looking at the treatment of pain post-surgery that indicated actually a combination of acetaminophen and ibuprofen was just as efficacious, if not more so, than opioids. So there's this sort of meme that opioids are the solution to significant pain, and the research indicates that that may not be the case.
Okay. I guess the thing I was looking at, and you guys may not be familiar with it.
Grothman, your time is up. Can you
I'm
wind up
sorry.
real quickly?
Sure, no, that's okay. Go ahead.
Do you want to
I'll yield the remainder of my time. I guess I have no time to yield. I guess I'll let you take the rest of my time.
Thank you, Mr. Grothman. We've come to the end of our question from our members. I want to thank all of you again for taking the time to testify before the subcommittee today. We've learned a lot from you, and we really appreciate that. We have a lot of work to do with it, but we've learned a lot from you. Mr. Desaulniers, do you have any closing remarks?
No, I just want to thank you, Mr. Chairman. I want to thank the panel. You were excellent, and I really think the emphasis should be for the subcommittee that we get the Department of Labor to act with a great urgency to actually implement some of the suggestions that the IG and the panel have made today.
Thank you, sir. A lot of people don't realize the importance of the oversight function of Congress, and I think that the hearing we've had today shows just how important that oversight function is. You've taught us a lot. That's very important. A lot of times when we're here on oversight, we're just trying to make sure that we're saving the taxpayers money or making government works more efficiently, and those are very important, laudable goals for oversight. Today we have the added factor of trying to not only improve the quality of people's lives, but in some cases save their lives. So this was a very important hearing from those standpoints. I personally learned two things, or I have two takeaways. One is that we, the federal government, the OWCP, et cetera, have a lot to learn from what's happening in state workers' compensation programs around the country and the carriers that are involved there. So we ought to get those lessons, transmit them over to the folks at OWCP, and expect them to learn from them as we've heard today. The second is that maybe we need to be having a conversation with people involved in the medical professions, I should say, who have licensure and oversight authority professionally. I know a lot of doctors, and they care deeply about their patients, and they want to do the right thing. But part of doing the right thing is policing your own. I'm a lawyer. It's hard to police other lawyers. You don't like doing that. But it's critical for the maintenance of the integrity of the profession to do that for lawyers, and it's equally critical to do it for people in the healthcare industry. So we've got some lessons to ponder here on the subcommittee. Y'all have been extremely gracious with your time today. There being no further business, the subcommittee stands adjourned.